What if I told you that some of the most dangerous patients in aesthetic medicine are not the ones with complications, but the ones who look completely normal? Today we're talking about body dysmorphic disorder, or BDD, and why treating these patients can damage your outcomes, your reputation, and your career. BDD is a psychiatric condition classified under the DSM-5. These patients are preoccupied with a flaw in their appearance, but the key point is this: the flaw is either minimal or doesn't exist at all. And yet, to them, it feels completely real. They may spend hours thinking about it, checking mirrors, comparing themselves to others. This isn't vanity. This is psychological distress that can affect their daily life, relationships, and functioning. Now, why does this matter in aesthetic medicine? Because BDD is not rare. Studies suggest up to 10 to 15% of patients in cosmetic clinics may have features of BDD. These patients are rarely satisfied, often request repeated treatments, and have unrealistic expectations. This is where many practitioners make a critical mistake. They think more treatment will solve the problem. It won't, because this is not an anatomical issue. It's a psychological one. So how do you recognize it? The patient focuses on a very minor flaw, or something you can't even see. They use strong language like, "This is a deformity," or "Everyone notices this." They've had multiple treatments before but remain unhappy. They may bring edited photos, filtered images, or unrealistic references. They are chasing perfection, not improvement. Emotionally, their reaction is often disproportionate to what you're seeing clinically. If you start seeing multiple of these signs together, you need to stop and reassess. These patients commonly fixate on areas like the nose, lips, skin texture, pigmentation, jawline symmetry, and tear trough, areas where perception is highly subjective and outcomes can never be perfect. So the most important question becomes, should you treat? If the concern is real and expectations are proportionate, you can proceed cautiously. If there is some distortion, you delay and reassess. But if the expectations are unrealistic, obsessive, or emotionally driven, you do not treat. This is one of the most important skills in aesthetic medicine, knowing when to say no. Many practitioners struggle with this, so here's a simple way to say it: I understand this concerns you. From a medical perspective, I don't think a cosmetic procedure will give you the result you're hoping for. I'm concerned it may not improve things in the way you expect. You acknowledge the concern, but you don't validate the distortion. These patients need psychological support, not cosmetic intervention. Referral to a psychologist or psychiatrist is the appropriate pathway, with treatments such as cognitive behavioral therapy and medication. Because if you treat a patient with BDD, they will likely remain dissatisfied. They may blame you, request repeated procedures, and they carry a much higher risk of complaints and legal issues. This is not about your technique. Even perfect work will not fix the problem. Your role is not to fix the appearance. Your role is to recognize risk and manage it appropriately. These patients need psychological support, not cosmetic intervention. Referral to a psychologist or psychiatrist is the appropriate pathway, with treatments such as cognitive behavioral therapy and medication. So remember this: BDD is not a cosmetic problem presenting with a psychological overlay. It is a psychological condition presenting in a cosmetic setting. And the safest injector is not the one who can treat everything, but the one who knows exactly when not to treat. Screening tools like a BDD questionnaire can help identify risk, but they do not replace clinical judgment. And consent alone will not protect you. Appropriate patient selection is the key. Thanks for watching. Like, comment, subscribe, and share to support the channel.